We move on to the next session now, which is minimally invasive vascular. And to chair the session, I would like to call upon Dr. Daljit Singh, sir. Dr. Singh is Professor and Head, Department of Neurosurgery at the GB Pant Hospital. And Dr. Paritosh Pandey from the Department of Neurosurgery at the Manipal Hospital.
So good evening. Without wasting time, I think we move on to the first speaker in this session. May I invite Takashaki Izumi, transvenous embolization for dural AV fistula.
Yeah, go. Thank you, Chairperson. It is a great honor to be able to speak to you today. My name is Takashi Izumi. I am from Nagoya, Japan. Nagoya City is located in the center part of Japan between Tokyo and Osaka. In Japan, all people have to wear the mask even now. So today I can feel comfortable after a long time. Thank you for the invitation again. And this is my content. The first is the indication of transvenous embolization for dural arteriovenous fistula. And then I present the three cases with a focus on image interpretation. And the indication of transvenous embolization is that there is no safe feeder for TAE. We should avoid to embolize the artery feeding cranial nerve, e.g. jugular branch of ascending artery or petrous branch of meningeal artery. In TVE, massive embolic material can compress and cause cranial nerve palsy, so I aim the selective embolization of the shunted pouch collecting feeders. Small core mass does not cause cranial nerve disorder. The main target is cavernous sinus dural AVF and anterocondylar conference dural AVF. So I present the three cases. First case is cavernous sinus dural AVF, 75-year-old female. Symptom is pulsatile tinnitus and conjunctival hyperemia. MRA showed the high signal intensity in cavernous sinus. And the right ECG shows the right ascending pharyngeal artery and the MMA and the arterial foramen rotundum is feeded, and they gathered into intercavernous sinus. And the drainer is left IPS and SMCV and SPS. Left IPS is used for TV as access route. Left ECG showed three arteries gathered in intercavernous sinus. These feeders gathered in almost same location, not completely, almost same location from right ECG. Left ECG showed slightly intercavernous sinus. And this is summary of DSA findings. We recognize we can get these findings in DSA, but the rotational angiogram can provide more information from MPR image in addition to 3D image. Here the 3D DSA fusion image like this. This image is at first glance clear, beautiful, but the details are not clear in areas that are close to each other. And there is little information of signal strength. So it is difficult to distinguish feeder and drainer. This is a thin slice source image of 3D DSA, right ECG. It is possible to distinguish between feeders and venous root depending signal value. The feeder is very white, very high, and it's very high, and shunted pouch is a little bit high, white, and the cavernous sinus itself is gray. And it is easy to understand in detail the structure that overlaps and is difficult to understanding in 3D images. And we got the MPR image from all angiogram feeding the shunt. Sometimes we get 3 or 4 rotational angiogram. Source image has more information distinguished with feeder, shunt, drainer, and so on. But 3D image is better visualization. 4 shunted pouches drained to intercavernous sinus are detected by source image, and localization is confirmed by 3D image like this. Here the schematic, this case, intercavernous sinus has 4 shunted pouches, and the right side is occluded. The embolization of only intercavernous sinus remnant does not compress cranial nerve and disturb to access the remaining the other vein. This is the merit of selective embolization. Here the access route. This is an 8x speed video, AP view. Here the IPS and the cavernous sinus and in the cavernous sinus and the right 2 shunted pouches. Microcassettes here and distal access cassettes here. I preferred to navigate the shunted pouch and embolize distal shunted pouch to get the complete obliteration. A little bit difficult to navigate select the shunted pouch. Now, like this. And then distal access catheter is navigated to intercavernous sinus. It's important to get the tight packing. Here the first pouch and the second pouch and the intercavernous sinus, and then third or the fourth shunted pouch was embolized. Coil mass localized in only intercavernous sinus. Right is post-treatment angiogram. Complete obliteration is obtained without complication and symptom cured after treatment. DSA 6 months later showed complete occlusion, and cavernous sinus is used for normal circulation. Here the second case is ACC idral AVF, 62-year-old female. Symptom is pulsatile tinnitus and hypoglossal nerve palsy. MRI showed the hypoglossal canal is high intensity. Right contralateral angiogram showed clearly artery and shunt and drainer. And to the contrary, ipsilateral angiogram is difficult to distinguish artery, normal arteries and shunted area, but we can see drainage route. But MPR and 3D image with high resolution is useful to understand the detailed angular architecture. Here is the MPR image. This image shows, for example, intraosseous feeder and intraosseous shunted pouch is here, and anterocondylar vein as drainage route and access route. And we recognize these structures in conventional image from MPR image to conventional image. The treatment is performed using fluoroscopic image. So the recognition in conventional image is essential for treatment. In this shunt has the medial side and the lateral side shunted pouch. Here the lateral shunted pouch is here. This pouch is fed by left occipital artery and the vertebral artery and the posterior auricular artery is here. Here the schematic of this case, the medial side and the lateral side shunted pouch are located both sides. And there are 4 outflow pathways. One is the IJV and the infrapetroclavian vein and the SPS and the cavernous sinus. These are from ACV through ACC and IPS. In this case, I embroidered the medial shunted pouch at first, here, and then lateral shunted pouch was embroidered. Here the final view. And this white arrow shows the hypoglossal canal. I preferred this oblique view along the hypoglossal canal. This angle is decided using MPR image. The reason I prefer to avoid the tight packing of the hypoglossal canal is important to avoid the hypoglossal nerve palsy. We can see the patency of hypoglossal canal clearly. Here the final view, complete obliteration is obtained and the tinnitus disappeared, hypoglossal nerve palsy improved. And here the last case, SPS dural AVF case, here. Here the only headache. And she desired the endovascular treatment. The shunt is very localized, like here, and the petrodollar drainer is here. In VAG, we can check normal perfusion, normal venous congestion, no venous congestion, and SPS was not opacified. 3D DSA and the MPR image showed the shunted pouch is located in SPS itself here, and here is this is outflated sinus type, and the origin of drainer petrodollar vein has varix is here. Enhanced MRI showed the high signal intensity signal along SPS. So SPS is considered to be occluded secondary, so it is possible to access the shunted pouch via occluded SPS. So we did TVE. We always always access to SPS via contralateral IJVB and conference. I succeeded to reach the shunted pouch, and using this type of access catheter is very helpful to support the microcatheter passing through the blockage. I embroidered the petrodollar vein and the shunted pouch, and like this, a complete obliteration is obtained. And here the postoperative MRA. And the patient discharged without complication. Here the last slide. I talked about following 4 points. And the indication of TV for dural AVF is that there is no safe feeders for TAE. The embolization for shunted pouch is useful to avoid cranial nerve palsy caused by compression. Since right source image is very useful to understand the detailed angular architecture, and the detailed distal access catheter is useful to support microcatheter. Thank you for your attention. finished.
Thank you, Professor Izumi. Very nice presentation. Any question from the house? One small query. You have used 20 plus coils in each case. Why don't you use a liquid embolic material to minimize the cost of coil placement?
Yeah. One is very small pouches I embroidered, so with a coil with liquid, you mean, but I use these coil is very soft, ultra soft or nano, so easy to fly to with liquid material. And the second is in Japan, liquid material is prohibited in venous side, only from arterial side. So it is difficult to use it.
Okay. Thank you so much. So I invite now my co-chairperson Paritosh Pandey is talking about flow diversion in the treatment of intracranial aneurysm. Paritosh, please.
Respect chairpersons, Dr. Sharad, thank you very much. Seniors and friends. So the general rule in the surgery should be the next generation should not use the same treatment as you have used in the previous generation. So these are the various advances in aneurysm treatment endovascularly. Surgically, of course, is a different matter. Detachable coils by Sabinenko, then we developed good microcatheters and wires, then detachable coils, then a very good evidence that these treatments work. Then we used balloon and stent for coiling for uncoilable aneurysms, then flow diverters, and now intra-aneurysmal flow diversion devices. So these are new generation stents who are placed in the parent artery at the level of aneurysm to disrupt intra-aneurysmal flow and provide significant rheological effects with potential changes in transmural pressure gradient. So what they do is intra-aneurysmal thrombosis, and then after that there is a neo. So this is composed of 25% platinum tungsten and 75% cobalt chromium, and made of 48 to 64 strands interwoven, and these are all braided stents. So these are the main mechanism of action: endoluminal reconstruction rather than endosaccular filling, changing parent artery aneurysm interface so that the inflow and outflow jets go away and induces aneurysm thrombosis. Along with that, there is a neointima formation over the stent which heals the area of the aneurysm which is happening, and then aneurysm shrinks with inflammation. So this is what is shown. These are some factors which are affect flow diversion mechanism: stent porosity, pore density, transition zone, and they lead to thrombosis. How did we get to this? First, there were treatments which were 2 stents or 3 stents were placed in the parent artery, and we saw that occlusion rates increase in size. Then, of course, there was a realization that only with coiling there is increased recanalization as the size of aneurysm increased, and challenge was to get the perfect metal density porosity which is adequate both to promote aneurysm thrombosis and not to close the parent artery, perforator or branch vessel. So first FDs were silk and pipeline endovascular device. These were the 2 main trials which were done, which led to FDA approval, which was PETA trial and the PUFS trial. So basically almost 90% of the aneurysms were occluded, and these are the various studies in which PUFS trials the occlusion rate was 81.8, which improved to 85.7. In PETA trial, almost 93% of these aneurysms, and these were uncoilable, clippable aneurysms, which will show in almost 76% of the aneurysms are occluded completely at the end of 1 year, and with PED and silk, and procedure related morbidity and mortality is around 9% of these things. So there are many, after this there are many flow diverters in market. There is Surpass, there is Pipeline, Fred, P64, Silk, along with pipeline endovascular device, and new generations of these things are coming. So these are the ones which are named. These are there. We can go ahead with various of these things. There is 30 to 35% metal coverage area. We have Fred, which is unique, as in it is a 2-layer design. Outer layer is 16 strand and inner layer is 48 strand, and silk is there. So how do we do it? We load with dual antiplatelets, aspirin, clopidogrel, prasugrel, or ticagrelor. We use a triaxial system, and then distal access catheter very, very close to the aneurysms. So what are the indications? Large and giant internal carotid aneurysms, blister aneurysms, dissecting aneurysms, fusiform, tandem aneurysms in displatted segments, recurrent aneurysms, and we'll go through each of them. Microcatheter is taken beyond the aneurysm, FD loaded with correct size and length, and with a combination of push-pull technique and unsheathing, FD is deployed across the neck of the aneurysms. So best indication, of course, is the large and giant unruptured IC aneurysm, either cavernous or supraclinoid, and this is almost the standard of care in these kind of aneurysms. So suppose this is one of the kind of aneurysms, unruptured paraclinoid aneurysm. You take the microcatheter, you place a FD, and if you want to, you can put a few coils here and put an FD across this aneurysm, and this aneurysm will thrombose. Again, another thing, go ahead and put FD and coils here, and you wouldn't even know in the control angiogram where the aneurysm was. Again, this is the cavernous aneurysm. Put a flow diverter across the aneurysm. Sometimes taking the microcatheter across this aneurysm becomes a challenge, but you can do it. And this is the FD pipeline endovascular device. And you can see where you would not be able to tell where the aneurysm was here after 3 to 6 months of area. So this is another case. So this has become almost the standard of care of these aneurysms here. So this is another aneurysm which is there, large cavernous aneurysm, place a FD, and it's completely reconstructed across the neck of the aneurysms. These are few examples of which has become a very, very standard technique and almost the standard of care in these kind of aneurysms. So from this, we can go ahead and completely pack the aneurysm here. So again, many of these things, you won't even know where the aneurysm was after complete reconstruction of these aneurysms. So this is a very, very common treatment which is done, and this is many of these aneurysms, almost 90% of these things get coiled. So these are the aneurysm here, which is completely gone at this point of aneurysm. The other common indication now has become blister aneurysms, which are very, very fragile aneurysms, causes extensive SAH, high risk with clipping and coiling. Bypass with occlusion is best surgical method, but FD is current treatment of choice. And you see that there is a large study which shows 87.5% complete obliteration, 68% good outcome here. This is a patient which we did 2 weeks back, SAH. Patient has a blood blister kind of aneurysm here. No neck here, very difficult to clip, very difficult to coil. We go ahead and place a flow diverter here across the aneurysm. You see this is the flow diverter here. I'll show you a short video of this as well. So this is the flow diverter here. It's difficult to see probably. Yeah, you can see quite nicely. If you see here that aneurysm is, the flow diverter is projecting into the aneurysm here, the blood blister kind of aneurysm. And this is how you unsheath the aneurysm. So this is microcatheter taken here. And we are pushing the wire here. The first struts of the flow diverter is coming out of the aneurysm. Very, very gradually, go ahead and place the flow diverter from the MCA to the ICA. So this is the ICA here, and this is the flow diverter opening up. Initially, it was very difficult to do these procedures, but now it's become much simpler with the advance of technology, and this is all how the flow diverter is placed here. So this is complete reconstruction of these aneurysms. Dissecting aneurysm again is common in the posterior circulation in vertebral pica aneurysms, and if you cannot do a parent artery occlusion, if it is difficult, or if there are branch vessels coming, then FD is preferred, but the only problem is you have to put a DAPT in these kind of aneurysms. So this is a dissecting aneurysm of the left vertebral artery. There is pica coming out of the aneurysm, so we could not do sacrifice of these aneurysms, and hence we went ahead and placed a flow diverter here across the aneurysm here, and this led to less filling of the aneurysm, and patient is due for a check angiogram in some time. Recurrent aneurysm, again we can do these things. This is a patient who was coiled 6 months back, came back with a large recurrence. This is an old case. Now we would call much earlier, and this is large recurrence. You go ahead and place a flow diverter across the aneurysm here. This is the flow diverter placed across the aneurysm, and this has led to complete healing of these aneurysms here. So this is the ruptured aneurysm is off-label use of FD except for a blister or the dissecting aneurysm, but sometimes we have to do it. There are few meta-analyses which have shown fairly good results for even saccular aneurysms of less than 7 millimeters, but the work is still in progress because of the use of dual antiplatelets. The patient who had ACOM aneurysm ruptured, which was coiled, and then patient had again a bleed with this MC aneurysm, and this was treated with a flow diverter placed across the aneurysm, which has led to complete healing of these aneurysms. Fusiform and dysplastic aneurysms can be also treated with these kind of methods, though with less success. This is one of these ACA fusiform aneurysms, which was placed with 2 flow diverters placed across the aneurysm, and led to the patient is due for a check angiogram. Posterior circulation, it is used less because of increased amount of perforators in these aneurysms. There is large mortality, and ischemic stroke is around 11%. So we avoid putting it beyond in the basilar or the basilar bifurcation, but we can go ahead and do this. Now we can also use what is called as an intra-aneurysmal flow diversion device, where we place a contour device or a web device inside the aneurysm. So this is how the web device looks like. This is placed inside the aneurysm, and this is what a contour device looks like, which is placed across the neck of the aneurysm. So these are flow diverters, but these are placed in the neck of the aneurysm, which reduce the flow in the wide neck bifurcation aneurysm, leading to their thrombosis. So this is a patient who had, which was where we put a web device in the middle cerebral artery. This is a patient where we have put a contour device in basilar bifurcation aneurysm, and I'll show you a small video. So this is the basilar bifurcation aneurysm here. We go ahead and, so this is, my catheterization is done. This is the umbrella-like device which is placed in the neck of the aneurysm here, and this leads to thrombosis. And I'll show you the post-operative angiogram at 3 months, which shows complete occlusion of this aneurysm here. So again, another basilar bifurcation aneurysm. This is a small basilar bifurcation aneurysm. We catheterize it. You place a small intra-aneurysmal flow diversion device, which is contour device like an umbrella. It sits in the neck of the aneurysm, leading to thrombosis of these aneurysms. So this is the umbrella-like device which is placed here, and this is how it looks like. These are the few MC aneurysms which we have treated with contour device here, and this is leads to complete healing of the aneurysm in some time. Initially we used some coils with the aneurysms in the ruptured cases, but now we just place a contour device and do not do this. So these are few examples of the MC aneurysms. ACOM aneurysm, which can be treated with contour device, ACOM aneurysm treated with contour device, ACOM aneurysm treated with fluid. So future directions, there are 3 major directions. We have seen that around 15 to 20% of the aneurysms still do not thrombose. So we have to do better case selection and expansion, and also expansion of indication. Then all these catheters initially used to be delivered through 27 microcatheter. Now we can use some of these in 17 microcatheter and 21 microcatheter, which are much more steerable. And then the porosity, so there are increase and decreases of porosity, leading to different kind of outcomes here. And the final advance is decreased thrombogenicity. So pipeline shield is already available. It has phospholipid chlorine on the struts, which is proven to reduce thrombogenicity. Whether we can use only single antiplatelets or shorter antiplatelet regime, we don't know. Other manufacturers are also using the same thing. So flow diversion is the modern revolution in the treatment of intracranial aneurysm, especially the ruptured aneurysm. It is the standard of care of large and giant IC aneurysm. Blister, dissecting, fusiform and dysplastic aneurysms are also indications. The role of ruptured aneurysm is still evolving. Intrasaccular flow diversion device is likely to be used more and more in wide-based wide-necked aneurysms, and future advances is likely to use thrombogenicity and expand extensions. Thank you very much for your kind attention.
Thank you, Paritosh, for covering it so beautifully. It's a very upcoming field, and I'm quite sure intracerebral devices is going to make a great impact, particularly wide location of aneurysm. Open for discussion, anybody? None. Okay, one question from you. Did you face any problem of flow diverter migrating into the aneurysm sac itself?
Yes, in the large aneurysms, of course, this is a major problem, and initially we had a huge problem because the larger devices were not available.
Yeah.
Now Derivo comes almost to 5 and 6 centimeters, so that problem becomes a little problematic. But till the time we had only 40 centimeters of the length available with pipeline vascular devices, frequently they used to migrate and we had to again catheterize or take it out.
It becomes very difficult at time, right? Yeah. Yes, Nishant.
Very nice presentation, Dr. Paritosh. I always wonder what happens in unruptured large aneurysms which might have thrombus inside. So do you have any problem navigating the flow diverters in those cases? Or?
No, those are almost those are better actually, because there is a thrombus which you can bounce off the microcatheter to the parent vessel. But if the entire sac is filling, then the microcatheter keeps going into the aneurysm and it becomes a major problem. So sometimes you have to struggle, and still one time it goes away.
Paritosh, that was a wonderful presentation. And you know, when I sit here, Daljit, I see how the history, how the whole thing has changed.
Correct.
You know what, in 1986-87, Vinko Dollens came up with extradural approach to intracavernous aneurysms. And we as young people like you at this point of time, that was the most passionate operation during that time for us, for me, to go intracavernous and try to maneuver and get to the carotid artery and get the aneurysm and clip intracavernous. And believe me or not, most of the time we used to blast in the theater, and that, the whole havoc, and one or two were successful, majority were unsuccessful. That was phase number 1. Then came the phase of bypass and doing occlusion of the artery. And that was also not such an easy game. You see, it prolonged game, long operation, difficult operation, do bypass, get artery, anastomose here, anastomose there. That was the phase number 2 of my personal experience. And now I see how these flow diverters have changed the entire game of not only intracavernous but supraclinoid. Posterior circulation is completely out of neurosurgical, direct surgical attack. Even ACOM and MCA, we are talking about not doing surgery. There is no question about the revolution. The word that you have used, that word is completely relevant in the field of endovascular. I am asking you one question today. You are also doing surgery, you are also doing endovascular. What do you think is the current status of surgery in ACOM artery aneurysm, in MCA bifurcation aneurysm, in some of the supraclinoid aneurysm? Do you still think there is some role, or you think all these things can be done by what you have shown?
Almost 95% of these things can be done if finance is not a problem. If money is
you
not a
know,
problem,
don't
then
talk about
almost
finance.
95% of these aneurysms can be treated by one method or the other. There are only very, very few aneurysms where there is a branch vessel coming out of the artery of the MC aneurysm, or these kind of things, or there are 2 branches coming out of the ACA aneurysm, and there is no safe landing zone of the intrasaccular flow diversion device, in which there is still some limitation of the endovascular thing. But intra-aneurysmal flow diversion device is a complete revolution again, and a large number of these ones where we could not safely clip coil, not clip, can be treated with this kind of method. So yes, it is going to be changing.
Same figures that you are giving, 95% were given by Jack Murray, Luc Picard about 15 years ago.
Yeah.
Do you anticipate that after 5 years or 10 years, in your personal experience, I'm not talking of anybody else's experience, do you think that the revolution will continue and it will lead to 100%, or is there some doubt in your mind? Or if there is doubt, what is your doubt?
Sir, I think it is a very nice thing that we have a large buffet of treatment available to us and not one treatment. So I think I'm not very passionate about doing it only one way. Whatever is the safest of the treatment, it should be done. And one of that buffet is of course surgical clipping, and that should always be there. But if there is a person who is very, very well skilled in endovascular treatment, I think he would be able to do almost 95%. 5% will still be there from branch vessel coming out and very fusiform dysplastic, which will need a bypass or something like that. But almost most of the garden will be filled by the endovascular treatment.
So in short, Daljit has been doing endovascular for quite some time, and he was the one neurosurgeon who promoted neurosurgeons to do.
Yeah.
I think you are the other one, and there are some more people. And to say the least, that we neurosurgery residents and young neurosurgeons should definitely learn this procedure. And if you ask me today, I will say ACOM artery aneurysm is still a game for surgery, and some, or if not many of the MCA bifurcation aneurysms are much easier to clip rather than to do endovascular. This is my personal feeling. Of course, there is no question about what you are showing and what has been going on in this field.
Yeah.
Thank you. Thank you so much.
Thank you.
Can I invite the next speaker, Dr. Girish Rajpal? Is Girish around? Nahi hai? Oh, great. Then the last speaker, is he around?
No, he's not here. Timo Krings.
Timo Kring, is he around?
So virtual, recorded presentation.
Recorded presentation. It's a very important topic, vessel wall imaging in the brain, arteriovenous malformation.
Dear Professor Chandra, dear Professor Goyal, and Professor Kato, it is my distinct pleasure today to speak to you, despite being virtual, on vessel wall imaging in brain AVMs at your esteemed conference of the ISMINS in New Delhi. What we will talk about in the next 15 minutes or so is a little bit off the topic of open vascular surgery, but I still believe that it's of important features, given that understanding vessel wall imaging will help us to understand what is happening in a brain AVM and why a brain AVM may bleed. These are my disclosures, nothing to disclose in relation to the contents of this presentation. Now, before we move to the AVMs, I want to make a little detour to aneurysms and why aneurysms form and rupture. And it was as early as 1999 that the Japanese group of Kataoka demonstrated that ruptured aneurysms had evidence for inflammation within the wall, whereas unruptured aneurysms didn't. Likewise, the group of Professor Hermes-Niemi in Helsinki demonstrated a couple of years later very similar findings. Ruptured aneurysms had evidence for inflammatory cells within the wall. Now, at this point in time, it was not clear whether these were related to the subarachnoid hemorrhage, these inflammatory changes, or whether the inflammatory changes preceded the subarachnoid hemorrhage. So further and indirect evidence was gathered that demonstrated that maybe there is indeed an interplay between inflammation and aneurysm rupture. For example, the Utrecht group of Gabriel Rinkel demonstrated that the incidence of subarachnoid hemorrhage is increased during epidemic influenzas, maybe because of a pro-inflammatory status. From the Framingham cohort, we found that those patients who had a high leukocyte count at baseline had a higher likelihood of developing over time a subarachnoid hemorrhage, maybe again due to a pro-inflammatory state. From the Isuya study, we realized that an anti-inflammatory treatment, i.e. aspirin, would allow us to decrease the number of subarachnoid hemorrhages. Well, this is indirect evidence. What about direct evidence of the interplay between inflammation and aneurysm rupture? We know from genetics that in the ruptured aneurysms, genes that are pro-inflammatory are upregulated, whereas anti-inflammatory genes are downregulated compared to unruptured aneurysms. We know from animal material or animal studies where we can induce aneurysms that then rupture, that those animals that are engineered to not have any leukocytes, they have less aneurysm ruptures and aneurysm formations. So in this group here, there was a lymphocyte deficient group compared to a wild type group. And the lymphocyte deficient group had significantly fewer aneurysm formations and ruptures than those animals that had a normal inflammatory response system. And then we can do even further evaluations and identify very specific inflammatory pathways that are activated in aneurysm rupture or that can be deactivated to prevent aneurysms from rupturing. What about human studies? In human studies, we can do vessel wall imaging and can identify that ruptured aneurysms, this ruptured MCA aneurysm, demonstrates enhancement. So you may say maybe the enhancement is related to the subarachnoid hemorrhage. Well, look at this case. Diffuse subarachnoid hemorrhage, 2 different aneurysms, but only one demonstrates enhancement, whereas the other one doesn't. And this was the culprit lesion. So vessel wall imaging in a ruptured aneurysm demonstrates indeed enhancement as a sign or surrogate parameter for inflammation. What about unruptured aneurysms? This aneurysm here was not ruptured, demonstrated thick enhancement, was treated upon with surgery, and indeed on surgery we found thick inflammatory changes within the wall of this aneurysm. And other studies have also demonstrated that if you see vessel wall enhancement, there's evidence for inflammatory changes within the wall. When I was a resident, I learned that aneurysms form and rupture due to hemodynamics. So do hemodynamics have nothing to do with aneurysm formation and rupture? Well, we found from work from our previous fellow, Charles Matouk, that depending on the shear stress forces, i.e. hemodynamic forces on the endothelium, specific genes can be up or down regulated. In particular, we found that if we have high shear stress forces, then pro-inflammatory genes will be upregulated. And therefore, we can now think about the following interplay between hemodynamics and inflammation. Hemodynamics, especially high shear stress forces, as seen here in these 1, 2, 3, 4 aneurysms, can cause pro-inflammatory reactions within the wall that will then lead to enhancement in those aneurysms that demonstrated these high shear stress forces as compared to those aneurysms that didn't have high shear stress forces. And this inflammatory change may predispose subsequently to rupture. So for the aneurysms, our current understanding is indicated here. Can we use this also for brain AVMs? Well, first, we need to understand why brain AVMs bleed. Is it due to high shear stress forces? Is it related to perinidal angiogenesis? Or do we indeed have inflammatory changes within the vessel wall? Or can we identify that some of these factors are interconnected to each other? So let's have a look at a couple of ruptured AVMs. This ruptured AVM here demonstrates significant significant edema surrounding the bleed. Now, a reabsorption edema classically appears only after 24 hours. So if you have already edema on the first presentation, it may mean that it was pre-existing. The other feature that we are seeing in this patient is that there's a focal outpouching, a focal aneurysmal outpouching pointing into the hemorrhagic cavity, right up here, right there. And we believe that this is the cause of this patient's hemorrhage. So what do we have in this patient with a ruptured AVM? We have an outpouching and we have edema. Okay, what about this patient? Significant edema already at presentation, which may indicate that it is pre-existing. And right there is a focal outpouching pointing into the hemorrhage. What about this unruptured aneurysm? Unruptured AVM with an intranidal aneurysm. Well, this unruptured AVM happened to look like this before treatment or 6 years ago, and looks like this now. And you can see that over time, an aneurysm formed in the inferior aspect of the AVM. And now we see that surrounding this aneurysm, we have significant edema in an unruptured AVM. Maybe this is an AVM about to rupture. Or look at this case here, where we have significant edema surrounding an unruptured AVM associated here with a pretty large intranidal aneurysm. And we believe that this may be actually an unstable AVM that may be more prone to future rupture. So we treated the aneurysm first and then irradiated the remainder, leading to complete cure of the AVM. Can we do vessel wall imaging in AVMs? Yes. And we can see that surrounding the rupture point, surrounding the aneurysm, we indeed see enhancement. So what about unruptured AVMs? We have here a patient who has significant edema, focal outpouching, and indeed the outpouching demonstrates thick enhancement, indicating inflammatory changes within the wall. Another example here, where we have thick enhancement and edema within this outpouching. Another example here, where we have a large outpouching, only edema in the posterior component, and this is where we demonstrate enhancement. But in all three patients, we see also something else. We see that within the outpouching is thrombus right here and right here. Thrombus right here. And thrombus in the posterior compartment of this outpouching where we have the enhancement. So we thought that maybe we are here on something. And we looked at all of our patients who had edema. And you can see here, indeed, this patient also had thrombus formation surrounding the area where we have edema. This patient had thrombus with the edema. These are old cases from Carotid Rouge, but again, you see outpouching with thrombus formation. Thrombus here, edema here. Large thrombus, thick enhancement, significant edema. All of these are unruptured AVMs. And you get the point. Edema, focal thrombosis. Here, more recent case, significant edema surrounding focal thrombosis in this large AVM that we then subsequently treated, as you can see here, with a complete cure. And the edema immediately redressed. So, what is the interplay between thrombus and edema? Well, maybe due to the recirculation of contrast within the venous pouches, we will get thrombosis. Thrombosis prevents the oxygen to go to the vessel wall, which will lead to local hypoxia in the venous wall. And this can lead to breakdown of the blood-brain barrier, matrix degradation, edema, inflammatory changes, and therefore the risk of rupture. And we do know that thrombus can be pro-inflammatory through the so-called neutrophil extracellular traps that have been found to be present in sterile thrombus, especially under high shear stress forces, and that lead towards an inflammatory response within the vessel wall. Together with Johanna Frozen, we looked at the inflammatory pathways within brain AVMs. And indeed, we were able to identify that within brain AVMs, there is a pro-inflammatory pathway activated from a genetic perspective. That's the cyclooxygenase pathway. And therefore, what I believe we are looking at right now is a paradigm shift from flow-related hemorrhagic complications to inflammatory or biological changes in the wall of the AVM that predispose an AVM to rupture. And therefore, I believe that vessel wall imaging may help to identify those brain AVMs that are at a higher risk of rupture. And with this, I would like to thank you very much for your attention. All the best and all my best greetings to New Delhi. Take care.
Okay, thank you very much, sir. Thank you. So with this, we come to the close of this session. We are again some 15 minutes we've gained. This is probably the first conference which is going before time and not after time. So thank you very much.
He's online. Any questions to be asked?
Yeah, Dr. Anil. Dr. Anil.
Can you hear me?
Yeah, Professor, from this learning which you have, what is the percentage of your unruptured aneurysms, especially multiple unruptured aneurysms, that you are treating with aspirin? What percentage of these aneurysms are you treating with
Excuse me, I mean,
anti-inflammatory drugs?
didn't notice he's a radiologist who's presented the picture of arteriovenous malformation vessel wall imaging. Okay.
Probably to Paritosh,
Yeah.
because
Yeah, no,
we have had this.
You want to answer that?
I'm also an endovascular neurosurgeon. And I
Okay,
can
sorry.
treat,
Please go ahead.
aneurysm. And so what we are doing in our practice is we are enrolling patients in the PROTECT-U study. The PROTECT-U study is a study that is organized by Nima Etmian from Mannheim and Marvin Vergaun from Utrecht. And we are randomizing patients, either giving them aspirin or not giving them aspirin. And then as our endpoint, we have aneurysm growth over time. If we see aneurysm growth over time, we assume that the aspirin treatment is not working. Now, do we do this with a 7 millimeter ACOM aneurysm? Of course not. I treat a 7 millimeter ACOM aneurysm on any given day. And we will not give just aspirin. But where I am doing it is in the unruptured 3 millimeter MCA aneurysm in an 85-year-old patient, where I am quite assured that this aneurysm will not rupture in this patient's lifetime. So in those patients where we are after a multidisciplinary conference between open neurosurgeons, between neurologists, and between endovascular surgeons such as me, we decide that we will observe the patient. In these patients, we will randomize them into either giving them aspirin or not.
Professor, is it safe to say that the AVMs which have edema, unruptured AVMs which have edema around them, should be we should be a little more aggressive in treating those ones with this vessel wall imaging and all that stuff?
That is correct. So don't get me wrong, we don't need vessel wall imaging in every patient with an AVM. Vessel wall imaging is just a tool that helps us to understand why certain AVMs react in a certain way. If I have an AVM that has significant edema and I see a focal outpouching, I will treat this patient. And presumably, I would not treat this patient with gamma knife as my first goal, but rather with a targeted embolization or with a surgical excision, depending on the Spätzle-Martin grading and again, depending on our multidisciplinary conference. These types of decisions are always decisions that you'll have to do in a team together with open and endovascular.
Yeah, Dr. Criggs, does this vessel wall imaging makes a difference in the management of grade 4 and high grade AVMs, like where to treat, not to treat, or such kind of decision making?
Yes, for sure. As I said, in the moment where we have edema surrounding and outpouching, and let's say it's a grade 4 AVM, and our surgeons would back out of this, I would go ahead and treat this compartment with a focal targeted embolization, as I believe that these can be areas that are like at a higher risk for future rupture.
Okay. And one last question. Is there any role of immunomodulators like in these patients? Because it's finally the inflammation that we are looking at.
I think that there is, as of now, very little evidence for this. We did find that the cyclooxygenase pathway is indeed activated in brain AVMs. And as such, if we have immunomodulatory drugs that are targeted towards the COX-2B pathway, that could be an interesting, again, study. But I think that the current immunomodulatory anti-inflammatory drugs do not necessarily go for the COX-2B pathway. A very simple drug to go for the COX pathway would be, well, any type of COX-B inhibitors, and therefore non-steroidal anti-inflammatory drugs, including, again, aspirin. And so maybe in the future, one may think about a study where we are looking at unruptured AVMs that we are deciding to follow. Again, not every single AVM that I see is treated, and give them either aspirin or not in a prospective trial, and maybe see whether there are those that develop an edema over time.
Fair enough. I think, thank you so much, Professor Timo Kring. See, vessel wall imaging is definitely going to be additional tool in the management of vascular malformation, be it an aneurysm or be it arteriovenous malformation. For very simple reasons, it is going to be a predictor of at least the one which is likely to rupture and one which is not likely to rupture. Silent aneurysms, incidentally detected aneurysms and AVM malformations, all the risk factors which we teach, which we enumerate, can help in predicting the rupture in these two conditions. This would be an additional tool available in guiding us what to do in those patients. Thank you so much. With that, we close this session and hand over to the organizers.
Thank you, Dr. Paritosh. Thank you, Dr. Daljit, for that excellent moderation for this excellent session. So now